Yeah, we're gonna go ahead and get started to stay on time. So on behalf of my co-moderator, I'd like to welcome you all to this next session on acute pancreatitis, current guidelines and standard of care. We have 5 fascinating speakers, 2 which will be virtual. Each talk will be about 12 minutes. We'll allow for 3 minutes of questions and we'll move on. We'll have 15 minutes at the end if we stay on time for more questions to all the panelists at the end. So it's my privilege to introduce the first speaker for today's session, Dr. Raman Muthuswamy from UCLA, will be giving us a talk on endoscopic management of walled-off necrosis.
Okay, well, good afternoon, everybody. Thank you for the meeting organizers for inviting me. So I'm going to talk about endoscopic management of walled-off necrosis. These are my disclosures. And I'm going to cover identifying the best candidates for this technique, some of the evidence behind endoscopic management for walled-off necrosis. And then I'll show you some videos about the technique and some of the challenges and where we can go from here and some conclusions. So, as you know, acute pancreatitis is a significant issue in this country. 15 to 20% will develop necrotizing pancreatitis, of which some will have prolonged issues and develop organ failure and can develop, again, either sterile or infected necrosis, which can mature into walled-off necrosis. So just as a brief review, again, walled-off necrosis is really when we have an acute necrotic collection that matures, gets encapsulated, and has a collection of either pancreatic necrosis and has a well-defined wall, usually occurring about 4 weeks after the development of necrotizing pancreatitis. So the question is, which patients with walled-off necrosis need this sort of drainage? I think it depends, obviously, if there's a suspicion of infection, about 20% will have that in necrotizing pancreatitis. We don't routinely need an FNA. Clinical signs are usually accurate. And as we heard from Dr. Besselink yesterday, so many of these patients may not need any intervention and may do okay with some conservative management and antibiotics. However, some will have ongoing organ failure, and many of these folks, a greater percentage will have infection. And then as very often we'll have patients with gastric outlet obstruction, biliary bowel obstruction, or persistent symptoms of pain and weight loss for which therapy may be appropriate. The bottom 3 conditions are pretty rare and really not managed endoscopically. So what do we look for as endoscopists when during imaging? We assess the size, the shape, and the number of collections. We assess the maturity of the wall. We assess the distance of the wall from the GI lumen. Ideally, we'd like that to be 1 centimeter or less. We assess for intervening vascular structures, although because most of these collections are fairly large, we can usually navigate a way around any vessels, even if they are there intraprocedurally. And lastly, we assess for the composition of the fluid collection that may determine the size or the number of drains, as well as the need for direct endoscopic necrosectomy. So general principles for treating symptomatic pancreatic fluid collections. Again, if it's in the acute setting, we typically try to delay. For pseudocysts, again, we typically just need drainage. And these are usually, again, after 4 weeks. And for those with walled-off necrosis, which I'm going to focus on, you'll need drainage. And in some cases, particularly in those with a great amount of solid debris, you'll need debridement. So what's the evidence for endoscopic management for walled-off necrosis? Again, there's several studies, but I'll sort of highlight just a couple of the main ones. This is, again, from the Dutch pancreatitis study group that was published in JAMA 9 years ago now. This is a randomized trial of endoscopic transgastric versus surgical necrosectomy. Again, this was looking at the endoscopic group, had a median of 3 procedures. And again, this was, at the time this happened, we didn't have lumen opposing stents, so this was using sort of the older technique. 2 patients ended up needing video-assisted retroperitoneal debridement in that group because of prolonged number of endoscopic treatments. The surgical group had 6 VARDs and 4 laparotomy. And in terms of outcomes, they noticed that there was a significant reduction in pro-inflammatory markers IL-6 and a reduced composite of the major complications and deaths. So it was only 20% in the endoscopic group compared to 80 in the surgical group. Obviously, a relatively small study, but important trial design. So the same group then did a question of endoscopic versus surgical step-up in infected necrotizing pancreatitis, which was published in the Lancet. So basically, they either randomized initial percutaneous or endoscopic drainage and then followed them. If they failed to improve, they got imaging to see if there was adequate drainage. If the drainage was inadequate, they did additional drainage. If it was adequate, they then watched them. If they failed to improve, then they did necrosectomy, whether it was endoscopic or VARD and surgery. So in this study, what they found was in terms of the primary endpoint, again, which was major adverse events or death, there was really similar between the 98 patients in the study. The death rate, as you see, separate was also similar. The main difference was in terms of the development of pancreatic fistula, 5 to 32% in favor of endoscopy, and a reduction in length of stay of 16 days. Interestingly, the costs in this study were not significantly different. And the authors sort of mentioned that the outcome of this study would probably result in a shift to endoscopic step-up approach as a treatment preference. So what about the timing? If you're going to do necrosectomy, should you do it at the time of initial drainage or delay it? This was a matched cohort study, again, small of 12 patients in each group. And they found that if you did direct endoscopic necrosectomy first, you had clinical resolution in 11 out of 12. During the step-up, actually, they had to have significant number, or essentially all the patients needed either IR or surgery. They also had a shorter stay and also a significant reduction in healthcare costs, unlike the prior study, doing sort of an accelerated approach. So one of the big advances in the field of interventional endoscopy is the development of lumen-opposing stents, which have really made access to sort of additional spaces, in particular, for pancreatic fluid collection drainage, for which it has an FDA indication, really transformed it because it sort of anchors the wall together and it really allows for a much larger drainage channel up to 20 millimeters. So this is a study specifically using lumen-opposing stents, 124 patients that found that technically 100% success. Clinical success was 86%, so only 14% needed to go to IR surgery, and of which only about 1 in 40 ended up actually needing to go to surgery. So again, endoscopic treatment appears to have similar efficacy, but potentially lower rates of fistula, shorter length of stay, and potentially lower costs, particularly in the era of some of the more advanced lumen-opposing stents. So I'll talk a little bit about technique in general, especially for when there's evidence of necrosis. I tend to use a larger diameter lumen-opposing stents. They're up to 20 millimeters now. Usually a single stent is what I use, although there is some data to suggest sort of this multiple gateway technique. But these stents are expensive, so we tend to try to use one at least to start. In terms of timing and drainage, the necrosectomy, again, it's on maturation of the wall, and I've sort of increasingly moved to direct endoscopic necrosectomy with the larger sort of lumen-opposing stents. The smaller caliber ones, as you'll see, we were concerned about dislodgement. The larger ones, I think we were less concerned about that, the initial procedure. And I'll discuss the interprocedural adjuncts with the video. So we'll start with sort of just the drainage technique. So here's a fluid collection. So the first thing we do is sort of measure it. So you can see that this is about 13 centimeters wide, about 9 centimeters or so deep. You can see some debris and necrotic material at the bottom there at the 5 o'clock position. We're measuring the wall to check the thickness, rule out vasculature. We then puncture a needle into the cavity, and then through the needle we deploy sort of the distal flange, which you see pop open there. We now pull back and retract on the wall, and sort of until we get a little bit of a deformity. And then we deploy the proximal flange, usually within the scope, and then sort of extrude that. And you'll see a video here sort of showing that happen. You can see now that there's the sort of from the gastric side here, and now it's very tight. So you can see we're sort of pulling that introduction, the guide wire there. And now you don't usually leave it like that because it's not very open. So you tend to dilate to the size of the lumen that you have. So at 15 millimeter, you dilate to 15, 20 to 20. So you can see the fluid collection is dramatically smaller at this point because the fluid will drain almost immediately. But then you're really focused with what's left. and some of the debris in the cavity. And this is not uncommon, where the debris will sort of pop right into the cavity and can actually occlude it. And so this can be a source of potential subsequent infection. So you sort of need to remove this or place a coaxial pigtail stent. In this case, we're going to do both. One of our big challenges is we don't really have good materials or devices to do this. So we tend to use general GI equipment like snares, baskets. So here we are sort of taking this out. You have to be careful about how tight you do this, otherwise you'll just break off the pieces. And so you're trying to get as large a piece as you can of this necrosum. Typically we dump it in the stomach, and it's just sort of tedious. These procedures can be sometimes several hours. Here we're placing a pigtail, both to protect the back wall of this cavity from the metal end of the stent, as well as to preserve its patency so that if any further necrosum comes, it doesn't occlude it. So I'll move on to sort of some new adjuncts associated with this. So how can we do this better? Hydrogen peroxide is thermodynamically unstable and decomposes to form water and oxygen in the presence of catalase, and it can serve as a debriding agent to dissolve and mobilize necrotic tissue and help effervesce at the junction of the healthy and necrotic tissue. This is a recent paper in the American Journal of Gastro, looking at 9 centers, some of whom the authors are here. Again, 204 patients, 122 that received hydrogen peroxide as an adjunct to the necrosectomy, and 82 was standard. And the clinical success was about 15% higher using hydrogen peroxide. The odds ratio for clinical resolution was 3.3 times higher and about 2.2 times higher for earlier resolution. You can see the improvement there on the Kaplan-Meier, with the red being the use of the hydrogen peroxide. No difference in adverse events, about 20 minutes faster, and different solutions used. So I'm just going to show a couple of videos here before I close. So this is, again, sort of what happens here. You have an occluded lambs here, so you're trying to pick it off with sort of forceps. Again, you break up in these things. These are some of the challenges, because this is very friable, very fragile tissue. So you can see you sort of use a tri-prong grasper. We tend to use a lot of objects we use to sort of retrieve foreign bodies for this, but they're really not ideally suited. So here's a hydrogen peroxide assisted necrosectomy here, which you'll see. We're going to infuse a solution here. There's variable amounts that you can use. And this helps kind of separate this and sort of more easily remove it, and either from the wall, or in this case from the stent. And you'll see when we pull this out here, that this has a fair amount of pus behind it. And so this is part of the reason why I think we often leave a coaxial stent. Now, for the interventional endoscopist, we wish it went this fast. This is one huge piece. You usually don't get this such a large piece, but it helps facilitate. And then now you can go into the cavity, sort of use some additional spray here, and I'll show you what hopefully it looks like when you're done. And sometimes this, again, takes several sessions. There can be large cavities. You may not be able to get into all the pockets. So, and sometimes we do this every week or so. It's variable, but here you can see the hydrogen peroxide sort of injected in lavage to help separate it. And then in the end, I'll show you what the cavity should look like. There's sort of healthy tissue there when you've got all of it out. So I'll close by talking about a new technology. This paper just came out in September online. This is a distal cutting window with an automatic tissue retraction device that actually can suction. These are the kind of tools. It's actually FDA approved now. And you'll see this is like a tissue morcellator. It sort of grabs the necrosum and sort of just swirls and pulls it up. And so in this trial of 10 centers, they had 30 patients. They had to have at least 30% solid debris with walled off cavities from 6 to 22 centimeters. Half of the cavities were able to be completely debrided in a single session, 2/3 in 2 sessions, the median of 1.5 interventions. And the procedure time was cut by about 40 minutes. And you can see how nicely that sort of can sort of both just grab that and pull it up. You can see the cavity at the end. There was 2 bleeds and 1 pneumoperitoneum, but again, promising technology. So in closing, really, we've made tremendous advances in endoscopic necrosectomy over the past decade. LAMs have really transformed our ability to access the walled off necrosis cavities and drain them. Larger diameter stents are going to facilitate drainage and necrosectomy, and we do need to balloon dilate post-deployment to maximize drainage. Coaxial pigtail stents can protect the cavity and prevent total LAMS occlusion by necrotic debris, as you saw. And we need improved devices like the one I just showed you to reduce the number of sessions. Still have some uncertainty on optimal stent choice, diameter and number. But again, these are complex patients that should be stressed in combination with surgery and radiology. Thank you.
Thank you, Raman. We have a few minutes for any questions from the audience. Raman, are there any contraindications for endoscopic management wall-off necrosis when you're asked to do one and you'll pass?
Yeah, I mean, I think you kind of have to see, I think that we do better when the cavity is sort of deep and not as wide. When it's sort of a very sort of transverse cavity, it's very hard for us to sort of get out to the edges. And it just depends on how sick the patient is, particularly some of these patients may be quite ill. And so you have to discuss, in conjunction with surgeons. But typically, the other thing is how close it is to the GI lumen, of course. If it's more than 1.5 centimeters away, we probably, although we are getting lambs with longer saddles.
And the hydrogen peroxide lavage, how do you intend to suck it all up before you take it?
Yeah, it's sort of wash lavage. Some people put it in their bottle. Some people would use a spray depending on the amount you're planning to use. So I think that's
you don't leave it in there.
Yeah, it's more to sort of lavage out in the spray. Sometimes you can leave some in there, I think, to loosen it up if you're planning to come back later. But I've seen more traditionally to try to use it to facilitate necrosectomy at the time.
Great. Mustafa?
Hi, excellent talk. Thanks, Raman. What's your personal opinion and approach to patients who are critically ill for immediate necrosectomy versus just draining and coming back another day? I know there's debate on that.
Yeah, I was initially sort of just place it and get out. And I think that was when we had smaller lumen opposing stents where we were afraid of dislodging it during that, particularly when there's a hard angle and it's not straight. As we've gotten into the 20 millimeter diameters, I feel more comfortable sort of exploring. And some of these people who have very high percentage of with necrosum, I tend to like to start sooner based on some of the data I showed you.
Even with critically ill patients, you don't see any decompensation?
Obviously we judge, we haven't had, in general, I think I like to get started. I haven't had an issue so far, but fortunately we haven't had so many that are critically ill that I've had to do.
And just looking for encouragement to get going.
Yeah.
Thank you.
All right, thank you, Raman. We'll move on to our next speaker, who is going to be coming to us virtually. Our next speaker is Dr. Yoshifumi Takayama. He is a professor and chairman at the Kandai University and will be presenting on Japanese clinical guidelines for pancreatitis. So if we can have his talk up, please.
Thank you, Chairman. Dear colleagues, I'm very sorry to be unable to attend the APA meeting due to the COVID-19 influence. Today, I want to talk about the Japanese clinical guidelines for pancreatitis. We have several clinical guidelines for pancreatitis, and one is acute pancreatitis, the one is for chronic pancreatitis, and the other is autoimmune pancreatitis. Today, I want to talk about the clinical guidelines for acute pancreatitis in Japan. We have several issues of the clinical guidelines for acute pancreatitis. And the first one is published 2003. And then we revised 4 times until now. Nationwide epidemiological survey was performed by the Research Committee of Intractable Pancreatic Diseases under the support of the government in 1987, using on the patient from the 1982 to 1986. In this cohort, the mortality rate was 4.4%. And the severity criteria in Japan was made using this cohort in 1987. And at that time, mortality rate in predicted severe case was as high as 30.1%. This is severity criteria of acute pancreatitis in 1990. This is a little bit revised from the original one, but almost the same. We selected these clinical signs and these laboratory findings to define the severe acute pancreatitis. After that, the necrosectomy for infected pancreatic necrosis was introduced with some modifications, as you know, and a specific treatment for severe acute pancreatitis was introduced. Peritoneal lavage, enteral nutrition, and selective digestive decontamination, SDD, and the continuous regional arterial retention cryotherapy, and the CHDF aiming cytokine removal, and so on. As a result, the mortality rate was gradually and significantly reduced from 30 to the 12% within 20 years. And then we introduce the clinical guidelines for acute pancreatitis in 2003. This clinical guidelines was the first clinical guidelines in Japan. In this issue, peritoneal lavage was not recommended, and cry, SDD, CHDF, and necrosectomy for infected pancreatic necrosis is recommended. And second revision was made in 2007. And in this version, transfer indication was clearly stated, and cry, SDD, CHDF, and necrosectomy was still recommended. In this criteria of transfer indication, the severe cases should be treated immediately at the facility capable of providing treatment of severe acute pancreatitis. If such treatment is difficult, the transfer was strongly recommended. As a result, the many severe acute pancreatitis patients was transferred to the ICU in the high volume center. So it was a little bit mixed up at that time. The third revised version was issued in 2009. That revision was corresponding to the revision of severity criteria in 2008. And cry, therapy, SDD, CHDF, and necrosectomy for infected pancreatic necrosis recommended weekly. And moreover, the pancreatitis bundle was introduced. This slide shows the severity criteria revised in 2008. The severity criteria was revised because mortality in a severity case, severe acute pancreatitis, was becomes too low. So we made it more strict. In this criteria, these 9 prognostic factors were selected, and 2 or more positive prognostic factors means predictor of severe acute pancreatitis. And this shows the performance of these prognostic systems using the data from the nationwide epidemiological survey in 2016. The number of the positive prognostic factors is in good correlation with the mortality rate, and ROC curve analysis shows good performance. And the AUC for predicting mortality was 0.86. This shows the pancreatitis bundle introduced in 2010. Now, this bundle consists of 10 items. One is repeated severity assessment. Two, the transfer of the severe acute pancreatitis patient. Three, etiology diagnosis. Four, gallstone pancreatitis treatment. Five, contrast enhancement CT study. Six, sufficient amount of fluid replacement. Seven, pain control. Eight, prophylactic antibiotics. Nine, early enteral nutrition. And cholecystectomy, at last cholecystectomy after the recovery. If the statement of six, sufficient fluid replacement was followed, the mortality rate is significantly lowered, and the number of statements followed is small, the mortality rate was significantly becomes high. So this shows the performance of this pancreatitis bundle. The fourth revised version was issued in 2015, corresponding to the revised Atlantic criteria. In this version, cryotherapy, SDD and CHDF, necrosectomy for infected pancreatic necrosis has no recommendation. On the other hand, endoscopic treatment, IBR, and minimally invasive surgery were introduced, and step-up approach for infected wound was recommended. The mobile application was made and opened. This shows that step-up approach for necrotizing pancreatitis recommended in this version. After the introduction of the guideline, the mortality rate was 12% to the 8% after the second revision, 2 revisions. And then the mortality rate is elevated to 10% due to the revision of severity criteria. Severity criteria are more strict. And then, however, after these 5 years, the mortality rate was 10 to 6% in 2016. And now, mortality rate is probably lower than 6% in Japan. However, there is some problems. In this 5 years, the mortality rate within 2 weeks has significantly lower, but the mortality rate after the 2 weeks, after onset, 2 weeks, mortality rate, no change. So it means we should concentrate on the improvement of the mortality rate in the infectious complications. This slide shows the EN and the prophylactic antibiotics use in 2016. EN performance rate is very low, still low, and the EN starting time is not so early. So the early enteral nutrition should be more disseminated. On the other hand, even in the mild pancreatitis patient, the all prophylactic use of antibiotics is very disseminated. So that is a problem. To achieve further improvement, the enlightenment of general practitioners to the clinical guidelines and the dissemination of the pancreatitis bundle is very important. To thorough dissemination of infection control, early enteral nutrition, and the proper use of antibiotics should be penetrated more. To proper treatment of infection such complications, improvement of the step-up approach will be necessary. Thank you very much for your attention.
Thank you. Do we have Dr. Takayama on Zoom? Okay. So we will invite up questions from the audience, assuming we can get them pulled up here. Hello, can you hear us okay?
Yes. Can you hear me?
Yes, we can. Thank you. Thank you for that
Okay.
wonderful presentation. So maybe I can ask a question as an endocrinologist and not a gastroenterologist, but in the Japanese system, how do you implement these guidelines across the country? Are you able to do that through an electronic health system, or an order set that goes widespread across the country?
Okay, so it is that's a very difficult point. As I mentioned in my slide, we have the mobile application to see the guidelines. So I think it's one of the tool to spread the guidelines. But in my region, south region of the Osaka area, I made an ancate between the among the general practitioners. So the penetration rate of the pancreatitis bundle is now still under the 50%, just 45%. So that's the problem, I think. Thank you.
Any other questions from our audience? Oh, is there one in the chat? I cannot read it very well.
Read the chat.
Maybe if anyone is able to read that out to us, we could certainly repeat it up here. So I think the question is getting at what do you think is the rationale for the lack of differences in the late mortality, despite some of the advancements that have been made, for example, in endoscopic therapy for necrosectomy?
So endoscopic treatment for the infected one, you mean?
What's that? No. Oh, Dr. Takayama, I think the question was, what are your thoughts as to why the mortality rate didn't change beyond 2 weeks despite the pancreatitis bundle? Yeah.
Oh, I see. So I think that it's the most problem is the prophylactic use of the antibiotics. So the most of the patient has antibiotics prophylactically. So for too long, or more than 2 or 3 weeks. So that is a point. That is a problem, I think. So I think we should say that we should disseminate the proper use of the antibiotics. I think that is the most important point, I think.
Okay, thank you very much. I think we'll move on to our next speaker.
Thank you.
Thank you, Dr. Takayama. Please hang on because we will take questions at the end of the session. And moving on to our third speaker, we have Dr. Bi-Chin Wu from Kaiser Permanente Los Angeles Medical Center, who will be talking on improving the prognosis of severe AP early and late phase, methods of prognostication, and potential interventions.
This one. Yes, thanks very much to the APA, the organizers and the chairs for the opportunity and the invitation to speak. My only disclosure is that I did not come up with this title, and whoever I upset on the planning committee, I sincerely apologize, because this is a tall order. Improving the prognosis of severe AP parentheses, early and late phase, end parentheses, methods of prognostication and potential interventions. Let me take a breath. Okay, so as I was preparing these remarks, we're in this session about current guidelines, state-of-the-art treatment. I'm not going to be reviewing any of the guidelines. Many of you participated in writing the guidelines. What I am going to do is try to unpack some of the concepts in the title to see if I can attempt to address them. So first, what is severe AP? What is the prognosis of severe AP? What is the early versus late phase of severe AP? What are methods of prognostication, and what are potential interventions in severe AP? And all that in about 12 minutes, that's right? Okay, well, I'll cover as much as we can. I think my purpose here is, rather than providing a comprehensive overview, is to give you a couple nuggets, food for thought. And my goal here is to really challenge the status quo. It was a wonderful remark by Dr. Lurch yesterday, and I think I'm probably committing career suicide and not going to be invited back for any further talks, but here goes. So what is severe AP? Well, we have the revised Atlanta criteria as well as the determinant-based criteria. And they classify acute pancreatitis into various categories of mild, moderate, and severe based on the degree of organ failure. And also in the determinant-based, it also includes infected necrosis and whether there's concurrent infected necrosis with persistent organ failure. And these constructs have been very helpful in guiding clinical research over what has been essentially the past decade. But I'm going to propose that, we should try to understand, why is there such a focus on severity? First there's this appeal that has face validity, there's biologic plausibility, right? That there's this local tissue injury with acute pancreatitis that leads to infected necrosis, and then systemic compromise. That's representing the more severe forms with organ failure. It also provides objective measurement, that there are standardized definitions for clinical research, and there's a framework for how we can collectively discuss acute pancreatitis. But the big question, is it clinically meaningful? And what I ask is, should we be really rethinking severity in acute pancreatitis? The concern is these are really static measures. Either you have mild or you have severe. There's no transition between. And how does it help in real-time clinical decision-making? Is it a tool that we can apply at the bedside? Well, there's really no way for me to determine whether a patient's going to have persistent organ failure when they've developed their organ failure at onset. Also, in terms of infected necrosis, there had to be something that prompted me to evaluate the patient for infected necrosis in the first place. It also shifts attention from other relevant outcomes in acute pancreatitis, long-term morbidity in terms of the sequelae, in terms of what happens to the patient after they leave the hospital. So to try to address some of these concerns, a few years ago, we gathered at the APA in Hawaii, and then also subsequently at Digestive Disease Week, several iterative sessions to develop a dynamic scoring system called the Pancreatitis Activity Scoring System. And the idea here was to develop a construct based on a modified Delphi approach, getting consensus opinions about what were the clinical parameters that resonated most among the experts who took care of patients with acute pancreatitis. This is what ultimately came out of it as far as a disease instrument that doesn't try to predict outcomes per se, but really is to assess, where is the patient in their disease course? Are they doing better today than they were yesterday? And what are the parameters that we should be really focused on? And you can see some of the usual suspects are here, such as organ failure, as well as SIRS, but also there were some patient-reported elements in terms of the amount of pain and were they tolerating a diet. And then there was this other one that was a bit more controversial when it came in about their opioid requirements. And I'll point out that there's been some nice subsequent work to help modify this scale, to help make it more broadly applicable. And some of that work comes from the Apprentice study. I'm sure Dr. Papakristal will be sharing some of the genesis for these revisions. But that said, one of the ways that we can think about that is those different domains, those key elements that providers have settled upon that help us assess patients with acute pancreatitis. Then the next question, what is the prognosis of severe acute pancreatitis? So I'm quoting a meta-analysis that was published some time ago, and this was looking at 14 studies combining the traditional parameters we think of as severe acute pancreatitis, persistent organ failure, mortality of 30%, Infected necrosis, mortality of 32%, right? These are the numbers that resonate with us, and we continue to quote them in our guidelines. But I'll draw your attention to the pointer trial that's been referenced in this meeting. And I'm always interested in looking at what happens in the control arm studies for these randomized controlled trials. And there, where they looked at patients with infected necrosis, the essentially control arm, which was delayed or conservative management, they noted a 10% mortality. That's a 69% reduction in mortality to being what's quoted in the literature. What has changed since that time? Well, this is part of an ongoing trend, and we see this in Japan, we see this across the world. Mortality has declined in acute pancreatitis. Now, unlike the previous speaker, I don't have significant shifts in management or guidelines to point to attribute this improvement in acute pancreatitis. All I can tell you is that acute pancreatitis does not get treated in a vacuum. Right? The healthcare field has progressed. If we look at the sepsis literature, this is a summary of trends in mortality across all different causes for sepsis. And you see there's been a universal decline in mortality, and we can attribute that to a lot of advances from critical care colleagues, emergency department medicine, not necessarily what we're doing specifically in acute pancreatitis. So then the question we turn to is, how do we improve prognosis in severe acute pancreatitis? Well, we see that even in cases of infected necrosis, it may make sense to delay or defer intervention. I'll note that in the pointer trial, over 30% of patients in the control arm improved without endoscopic intervention, antibiotics alone. And then that question that was just raised about what happens in the late causes of mortality. There's this concept, a very nice talk on Wednesday, calling attention to the dynamic frailty index. It's an extension of this concept from the critical care literature about chronic critical illness, this persistent inflammatory immunosuppression and catabolism syndrome, the PICS syndrome. And this is this concept of fewer patients are dying, but there are more and more that are lingering in the intensive care unit, suffering from malnutrition, this catabolic state. How do we measure, treat this, and intervene? And I think it's not necessarily specific to acute pancreatitis. I'd like to take you through a thought experiment because we're often faced with the question, why don't we have specific therapy in acute pancreatitis? Well, what if we had the miracle drug that reduced mortality by 50% in patients with infected necrosis? Based on the sample size from the pointer trial, we did a study of over 1,150 patients. And I'll call your attention to, in that trial, they were able to accrue 100 patients across 22 centers over 4 years. Simply, there aren't that many patients with infected necrosis in the world to demonstrate efficacy. So the argument here is that the reduction in mortality is not an achievable endpoint. I say that not to discourage anyone in this room, and I'm not discouraged by that as well, but it's really to focus our attention on alternate endpoints that are more relevant for the vast majority of patients with acute pancreatitis. So if we turn our attention to, if we rethink severity, we're also rethinking the evolution of SIRS in acute pancreatitis and sepsis. I think it's been really a great meeting, and there are a lot of unifying concepts. And one of those has been this coming together alignment of the role of the immune response in acute pancreatitis, which is conserved across many different disease states. So historically, we think of the overactive pro-inflammatory response. Then subsequently, the paradigm was about a compensatory, anti-inflammatory response syndrome. To more recently, and we heard about this on Wednesday, this simultaneous overlapping of both the pro-inflammatory and the inflammatory mediators, and the early adverse outcomes occurring in the setting of the disequilibrium where the pro-inflammatory response exceeds that of the anti-inflammatory. And then there's also progression to more of the PICS syndrome that I alluded to earlier. And I think when we're thinking about interventions, we really need to break this apart and think, are we targeting pancreatitis? In which case, we're thinking about those complications that are specific to pancreatitis. For example, when we're talking about debridement of the symptomatic necrosis. For example, if we're talking about relieving biliary obstruction in patients who have concurrent cholangitis, that's unique to pancreatitis, makes perfect sense. But if we're really talking about preventing or altering the course of severe acute pancreatitis, we're really talking about modulating the immune response. And I think it helps us to think more broadly that this is not something that is specific to acute pancreatitis, but really in trauma, infection, burns, acute pancreatitis, that whole immune risk cascade are areas that we can target for further intervention. And I bring this study up, which looked at, it was a very nice study looking at machine learning approaches to identifying early markers in acute pancreatitis. And this was within 2 days of onset of symptoms. And what they found was that there's this 5 cytokine panel that was really associated with the development of traditional definitions of severe acute pancreatitis. But what I'll call your attention to is that this is a very early process, right? That this is something, if we're thinking about trying to interrupt the pancreatitis, the horse has already left the barn. It's really modulating the immune response, even by day 2 after symptoms, which is often by the time we're seeing them in the hospital. I'll comment about the prognostic indicators. At the bedside, one of the most useful is SIRS. This is a study from Vikesh Singh when we were at the Brigham together. And one of the really helpful aspects of this is that SIRS is highly sensitive, meaning that patients that do not demonstrate SIRS during their early course almost never run into issues about adverse events and complications related to their pancreatitis. And how can this be useful at the bedside? Well, if we could actually use this to help direct our management, because SIRS is not only a marker, but it's a dynamic reflection of what's happening in the disease course. So if we take the vast majority of patients, 70 to 75% that do not have evidence of SIRS, they can be treated with something I refer to as an enhanced recovery pathway. Whereas those who do have SIRS, the 25 or 30%, they will be treated with a volume challenge and assess their response. In almost half of cases, the SIRS will resolve, and they can also be treated with enhanced recovery. And for those of you who may not be familiar with enhanced recovery, I would direct you to the surgeons in the room who are likely much more familiar with this concept. But the idea is really about these core treatment pathways that are designed to expedite recovery in hospitalized patients. It's based on principles from enhanced recovery after surgery. It's been demonstrated to reduce length of stay and improve patient satisfaction in colorectal, as well as abdominal surgeries. And it really involves bringing together several concepts that are relevant to acute pancreatitis, including optimizing early nutrition, multimodality analgesia, sparing the opioids, as well as a balanced fluid resuscitation and early ambulation. So I see I'm out of time at this point, so this is a reasonable place to stop. I've already committed several cardinal sins by challenging our notions of SIRS and talking about mild acute pancreatitis. So I'll stop now and be happy to take any questions.
Thank you, Dr. Wu. Any questions for the speaker? While Dr. Hossein comes up, what's the future of PASS?
So I think the PASS, the modified PASS, which removes the opioid score, makes it more broadly generalizable. I think it's more, I would hope that it's more useful for clinical research purposes so that you can track the patient's progress, really balance cohorts across different regions and countries. I think from the clinical aspect, it's most helpful when you break it apart and look at those individual aspects, because rather than thinking of this as just one single marker entity, the PASS comprises both the organ failure scales as well as SIRS, but also those patient reported outcomes, which I think are important when we're assessing the patients at the bedside.
Dr. Hossein.
Great, thank you, Beechan, great talk. Just a comment, really. The first is, I think you get a pass on your comments. That's just a joke. But the second is that, when I was a medical student in the late 90s, cholecystectomy was being scrutinized much more than it had been before. I still remember that as I was on the wards, and the question was, why should we do laparoscopic cholecystectomy when we've got open cholecystectomy? I know there are surgeons here and they can probably speak to this much more, but because people don't die from open cholecystectomies. But the whole idea was, can we improve every aspect of outcome, hospital stay, pain, quality of life, etc. And I just applaud you, because I think those are probably the more important aspects that we need to focus on now. And so it's just a commentary that I think many other fields have done this kind of introspection much sooner.
Well, thank you for your comments, Sohail. And I would expand on saying, as a clinician, I'm not so much focused on what can we do to improve this patient's pancreatitis, but rather, what are the therapies that could benefit my patient who has pancreatitis? That's one area to frame it. And then I do think that it's very relevant for us to think outside of this room, right? That if we can adapt instruments and therapies from other fields, I think that should be encouraged. If we can collaborate with other areas where there are promising agents and interventions, I think we'll be able to advance treatments much faster.
Thank you. Any other questions? Thank you, Dr. Wu.
Thank you. Our next speaker will also be giving a virtual talk, Dr. Peter Hedgie from Semmelweis University, where he's an internal medicine specialist, gastroenterologist, and clinical pharmacologist. And he's the doctor of the Hungarian Academy of Sciences and deputy chair of the clinical and veterinary science section at Academia Europa.
So dear ladies and gentlemen, thank you very much for the very kind invitation to speak at the prestigious APA meeting. It's really, really a shame that this year I cannot attend due to COVID-19. But if I look at my disclosure, it's very clear that I miss Miami and the personal meetings and discussions. However, during the presentation, at least I tried every of my effort to mimic the Miami feeling. So let's go back to the topic. Actually, nutrition is really very important during pancreatitis. And if I look at the current IAP APA guideline, the nutrition support should start in predicted mild pancreatitis whenever the abdominal pain is decreasing and the inflammatory markers are improving. In addition, enteral tube feeding should be the primary therapy in patients with predicted severe acute pancreatitis. However, if we look at the recent article published in Pancreatology, there is a significant variability in the use of tube feeding in acute pancreatitis. Therefore, it's very important to read what and how we are doing actually in this topic. So why is it important to give energy to the patient? I think if they think about how the pancreatitis is developing, it's very important that both acinar and ductal cells are suffering based on bile, ethanol, or fatty acids. And one of the very early signs during acute pancreatitis is the mitochondrial injury and ATP depletion, both in ductal cells and acinar cells. And actually, these kind of ATP depletion will diminish the cells, intraacinar activation of trypsinogen, acidosis, and decrease of bicarbonate secretion will. Therefore, giving energy back to the patient is really beneficial. We also made plenty of studies, experimental studies, especially in the ductal cells, where we gave back energy to the cells, and the cells survived, and we could see that in improving CFTR channel activity. And the Liverpool group and David Cliddle did a very nice experiment when he gave energy back to the acinar cells, and also actually the cells survived and the acinar cells condition improved. So of course, but the question is whether early energy supplementation to the patient would be beneficial or not. So Katalin Marta, in our work group, did a meta-analysis looking at in severe acute pancreatitis, whether starting feeding in the first 3 days would be beneficial for the patient. And it was very clear that in all primary endpoints, giving early feeding was beneficial. However, we also looked at the mild acute pancreatitis, and we found that also if we looked at surrogate endpoints in the analysis, that even patients suffering from mild acute pancreatitis get benefit from early nutrition. During my Page University time, we had a huge amount of patients in acute pancreatitis. And even in the first year, we found a huge benefit of starting the tube feeding in patients, nasogastric feeding on day number 1. And we found that whenever we started the feeding early for the patients versus other institutions where they started the feeding in a late phase, we get a better outcome after disease. The patients spend less number of days in the hospital. And finally, whenever we looked at the mortality decreased even in a severe form very well. Also, the necrosis and the necessity for antibiotics decreased as well. So of course, early energy and early oral feeding is important. However, the question is how early should we start the energy? The Dutch Pancreatitis Study Group made a study and published it in the New England Journal of Medicine, showing that early tube feeding is not beneficial or even equal with an on-demand feeding. However, in this topic, they just build up the energy restoration for the patient, and in the first 3 days, neither of the group received high energy. Therefore, we developed the study, which we call the GUIA study, the general utilization of energy back to the patient, in which we try to give energy back to the patient. In a one group, they get high energy, and in a low group, they get low energy. And the primary endpoint, of course, the multi-organ failure and mortality. This study protocol has been published, and we wait for the interim analysis. However, currently, due to COVID-19, the study development is decreased, but the main aim of the study to look at from the very early stage, the high calorie versus the built-up calorie for the patient. We also investigated in a big international cohort, whether what is the current practice during enteral feeding. So we looked at 1,421 cases, and this kind of population very well represented actually a general cohort of acute pancreatitis. And what we found that 61% of the patients didn't get tube feeding, while 39% received. In 200 cases, actually they started on day 1. 143 cases they started in day 2, and 52 days they started on day 3. We looked at what made the doctors initiate actually the tube feeding. It was some biomedical parameters, laboratory parameters like CRP or LDH, or it was also in a radiological investigation that most cases when the CT showed necrosis for the patient, the doctors immediately started enteral feeding. If we look at the results, how the severity of these groups are in a non-enteral feeding, most of them were mild pancreatitis, so we can feel that this is a good method not to give feeding for this group. In the other groups also were seen that in those cases where the patient's condition were worse, they started the enteral feeding. However, when we looked at the final answers that how many patients received enteral feeding from the severe group and which one didn't get this, we see that these practice resulted that still 22% of severe form of pancreatitis did not get enteral feeding due to not having very good early markers for severe pancreatitis. And if you look at the mortality in the non-enteral feeding and enteral feeding groups, there were a huge difference. So if we would like to have the take-home message, we can say that in predicted mild acute pancreatitis, the start of oral feeding should be started whenever the patients have no pain and oral feeding and the laboratory parameters improving. However, if we have any kind of doubt, if there is a predicted severe pancreatitis, tube feeding should be the primary therapy. And I would strongly suggest that there is no harmful to start this kind of therapy early. So if anybody has any doubt whether this is a predicted severe or mild pancreatitis, I would suggest to start the tube feeding as soon as possible. So thank you very much for your attention, and thank you very much indeed for the very kind invitation.
Thank you. If we can get Dr. Hedgie up, we can open this session for questions. Okay. Hello, can you hear us okay?
Yes, very well.
Okay, welcome. Excellent presentation. Thank you for your talk. So while we wait for audience members to come up with questions, I'll take the first question here. One piece of data that I haven't personally seen in the feeding for acute pancreatitis is whether nutritional status at baseline makes a difference. Is early feeding indicated if someone is malnourished, for example, and doesn't have as much endogenous energy store? A well-nourished adult has, liver glycogen for 72 hours, but someone who's undernourished may not.
Actually, I think concerning the calorie, it hasn't been tested in randomized clinical trial whether the amount of energy from the very beginning of acute pancreatitis would be beneficial or not. Of course, I think the study has to be finished to get the answer. Currently, what I can say that there is definitely not harmful to start the feeding early. However, it is still not proved that high calorie at the first 24 hours would be beneficial or not.
I think there's a question in the chat. Again, unfortunately, the moderators are too far away from it to see. I think it's from Robert Sutton. Can you read it, Peter?
Yeah. So concerning the Guyash trial, we need around 60 patients actually to reach the interim analysis, the 50%. So I definitely hope so that within a year we can have the interim analysis results to present.
Excellent. Miklos? Hi, Peter. Good to see you. Oh, I think your mic is not on there. Yeah.
Hi, Miklos.
Is it good to see you and hear you, Peter? Obviously, if you visit different centers, there's different practices, how often they use early enteral feeding. So what's your experience? What determines whether a center really aggressively utilizes this approach or just they never hardly ever do it?
I think it's usually the local protocols actually which decide, and usually the older doctor or the more senior doctor which actually use Carentia in the past, they usually start the enteral feeding only if there is necrosis in the pancreas showed on the 3rd or 4th day, or there is already a severe pancreatitis. They don't even use nasogastric feeding, and they are not accepting the concept that low volume energy to the stomach is beneficial, because they were in the school when they use nasojejunal feeding only. And of course, putting down the nasojejunal tube, it's much more challenging. You need radiology or endoscopy to do so. In those centers where there are younger doctors, for example, who already has experience in the nasogastric tubing, they usually start the feeding earlier, and also they start the oral feeding. So this is just a general issue what I can see. However, of course, we haven't investigated it in detail.
All right. Thank you, Peter. It looks like that's all of our questions for now, but we have one speaker left, and then we will reconvene for a short discussion panel.
Thank you very much.
Thank you. Our final speaker for this session is Dr. Georgios Papachristos from the Ohio State Medical Center. He'll be speaking on international trends in treatment of pancreatitis, differences in treatment patterns. George.
Okay, thank you. Good afternoon. First of all, I would like to share with you how happy and excited I am to be in this meeting. This is my first in-person meeting post-COVID, and it's so great to be able to see you, all my friends and colleagues through the years, and interact with you. I was assigned to give a talk with the title of International Trends in Treatment of Acute Pancreatitis. This traditionally has been a challenging topic to discuss. We do have guidelines, societal guidelines, and updated guidelines. AGA recently updated the guidelines in 2018. But up to recently, I don't think we have a very good grab or handle of how these guidelines are actually are they being used in real-time clinical practice. Moving. So these are my disclosures, and my main disclosure, I'm so excited to be here. And I would like to thank APA for a great event and also very strong scientific speakers. Congratulations to all of you. So to address this challenge, back in 2014, a group of international pancreatologists met and formed Apprentice, this international collaboration. Our initial goal was to establish a multi-center research platform with the first step to develop a prospective registry from high-volume international sites so as to be able to assess real-time acute pancreatitis trends to include demographics, management, and outcomes in acute pancreatitis around the world. And in the future, we also want to use the Apprentice platform to perform randomized controlled trials in a diversified acute pancreatitis patient population. I would like to thank the Collaborative Alliance for Pancreatic Education and Research that has been sponsoring Apprentice for several years now. And as you can see in this figure, the idea came up in July of 2014, and subsequently we spent almost a year working on the methodology and the development of questionnaires. So very thoughtful and detailed questionnaires were developed prior to the initiation of the study. Subsequently, we had the plan phase that lasted for around 3 months. And the main phase started in April of 2016 and completed in January of 2018. So all the data that we gathered were within the last 5 years in a prospective manner. So I do believe that they do reflect current management practices. So phase 1 has been completed. And we can report that 22 sites are across the world were involved with a total of almost 1,700 patients prospectively enrolled. And as you can see in this figure, there are mainly 4 geographic areas representing 4 different continents. We have North America, Central and South America representing Latin America. We have Europe and also India representing Asia. And as you can see in this diagram, the subject distribution across the Apprentice sites and geographic areas was very balanced. So there were more than 300 subjects involved and enrolled in each of the 4 geographic areas. Last year, we published a paper at the Clinical Gastroenterology and Hepatology Journal on the worldwide variations in demographics, management, and outcomes of acute pancreatitis. And today, for the sake of this talk, we're going to be focusing on the management of acute pancreatitis around the world. Whew, it's hard to read now. So the first topic that I'm going to focus on is the use of intravenous fluids. And we focused on over the first 24 hours of admissions. And our first area of interest was the amount of fluids. As you can see in this table, 3 out of the 4 geographic areas, India, Latin, and North America, in these areas, the patients received similar amounts of fluids with a median amount between 3 and 3.2 liters over the first 24 hours. However, in Europe, the amount of fluids that was administered was significantly lower with a median amount of 2.5 liters. Moving on into the IV fluid type, the 2 main types that were used throughout the world were lactated ringers or LR and normal saline. But again, there were significant differences between geographic areas. I think India was the champion on that aspect, using LR in 92% of patients. Almost all patients in India are receiving lactated ringers. In contrast, LR was used in a good amount in Europe, 77%, and only 49% in North America, despite the fact that we're now several years after the very important landmark paper by Beach and Wu and the Brigham group. Finally, in Latin America, normal saline was used in 61% of patients, and then Hartmann solution was used in around a third of patients. And I just want to remind you that Hartmann's is a balanced solution, very similar to LR. I don't think that lactated ringers was available in the sites in Latin America. Moving along to following after IV fluids in the second area of interest as far as management, we focused on pain management. And we mainly assessed the use of non-steroidal anti-inflammatory drugs, the use of tramadol and opioids. And as you can see here also from the table, there were a significant difference between geographical areas. Europe mainly used non-steroidals anti-inflammatory drugs in 68% of patients, whereas in India, tramadol was used in the vast majority of patients, 91%. Now, the striking results were in opiate use. So the sites in North America used opiates in almost all patients, 93%, whereas the rest of the world was only giving opiates in 1 to 4 patients, in only 27%. And even moving a step further, administration or prescription of opiates at the time of discharge, as you can see again in North America, 64% of patients went home on opiates, whereas in the rest of the world, this was only 2.7%. So a striking difference on pain management patterns as well. From pain management, moving along to nutritional support, of course, Dr. Hegi gave a very nice talk into that, but do we really follow the guidelines? We know that enteral nutrition, we have very strong evidence that enteral nutrition is superior to TPN. Indeed, in Europe, our colleagues do follow the guidelines. Europe was the area with the highest ratio of enteral to total parenteral nutrition. For every 10 patients with moderately severe or severe pancreatitis that required nutritional support, only 1 received TPN. How about the rest of the world? As you can see, India was on the other side of the spectrum. In India, actually, TPN was used more commonly than enteral nutrition, with an enteral to TPN ratio being 1:1. In Latin America, the enteral to TPN ratio was 3:1, and North America, we were more or less in the middle with an enteral to TPN ratio of 5:1. Moving along from enteral nutrition to interventions, I will start with ERCP. North America, by far, was the geographic area was ERCP was most and more commonly utilized in patients with biliary acute pancreatitis in a percentage of 45%. So 1 to 2 patients that comes in with biliary acute pancreatitis in the US gets an ERCP, whereas this is only 14% in the rest of the world. Moving along to same admission cholecystectomy, we have very strong data now, very strong evidence to support performing cholecystectomy during the same admission. The champions on that was Latin America, with around 60% of patients with biliary acute pancreatitis receiving cholecystectomy during the same admission. Overall, here in the US, we're not doing that bad, but you can see on the other end of the spectrum, India, with only 15% of patients receiving same admission cholecystectomy. And all these differences were statistically significant, of course. Finally, early pancreatic intervention. There is more and more evidence now to avoid early intervention and use a step-up approach. Again, in India, early pancreatic interventions were very common in patients with moderately severe or severe disease. Around 1 to 4 patients, 23%, received an early pancreatic intervention. This was defined as an intervention within the first 2 weeks, whereas only 7% in the rest of the world. How about late interventions in patients with pancreatic necrosis? Unfortunately, the apprentice study was not designed to answer this question. So for this particular question, I will use some of our prospective data from the University of Pittsburgh that were published in Pancreatology in 2017, representing practices in the US, and also data from the Dutch Pancreatitis Study Group that were published in Gastroenterology in 2011. So what we found at the University of Pittsburgh in a single center prospective registry was that intervention for drainage or debridement of necrotic collections was performed in less than 50% of all patients with necrotizing pancreatitis. The percentage was only 44%, with a median intervention time being 45 days from the onset of the disease. Similar findings were also seen in the large European cohort from the Dutch Pancreatitis working research group. So as you can clearly see, current practices are not to intervene in the majority of patients with pancreatic necrosis. How about types of intervention? In the US, we're moving more and more into minimally invasive procedures in contrast to open necrosectomy. And at the University of Pittsburgh, at the time of the publication, the three main types of minimally invasive procedures that were utilized were laparoscopic necrosectomy performed by our surgeons, percutaneous drain placement by our abdominal radiologist, or endoscopic drainage debridement by our therapeutic endoscopists. So to conclude, there are significant differences in acute pancreatitis management approaches seen around the world, as the apprentice data confirmed. Adherence to current evidence-driven societal guidelines vary significantly between different geographic regions. And again, only a minority of the described practice patterns can be explained based on resource availability. One example was not that LR was not used in Latin America, where it's not available. I would again like to highlight that certain aspects of acute pancreatitis management lag behind evidence. And I want to bring two examples. Clearly, in North America, we appear to overuse ERCP in patients with biliary pancreatitis, but also there is clearly an excessive opioid administration, both during hospitalization, but also prescribed at discharge. And also another example, striking example, is India, where clearly there is overuse of TPN, despite the strong evidence, and also overuse of early pancreatic intervention in patients with moderately severe or severe acute pancreatitis. So clearly, we have to do a better job as an organization, but also individually, into augment the clinical implementation of therapeutic approaches supported by strong evidence in acute pancreatitis. Ending up, I would like to highlight the apprentice collaborators. This phase one of apprentice has been a lot of stuff, and as you can see, we're very proud. We're a very diverse group with investigators from India, Lithuania, Mexico, Paraguay, Romania, Argentina, Italy, Greece, and Spain, and of course, several sites in the US as well. So we're hopefully, now that COVID seems to get under control, we're working on our phase 2 study in apprentice. And I would like also to thank my team and collaborators at Ohio State University for their continued support. Thank you.
Open for questions. George, I have a question. You nicely descriptively showed worldwide variation in various aspects of management, particularly where certain regions seem to have lacked in following the evidence. I guess in your database, did it matter? Did you see a difference in length of stay? Did you see a difference in mortality?
There were some difference in clinical outcomes. It appeared that patients in Europe tend to be older, sicker, and have higher mortality in comparison to the rest of the geographic areas. Granted, patients in Europe also received less amount of fluids in the first 24 hours. This is an association, but it's very hard in a prospective observational study to make more granular conclusions based on that. We tend to send patients sooner at home in the US. I think this is also a lot driven by our insurance, if you wish, patterns and establishment. Patients tend to stay longer in the hospital in Europe and Latin America for sure.
Thank you. Sohail?
Great, thank you, and thank you, George. I really am amazed by the prospective nature of the study, the multiple centers, and you commented on some of this, but I thought I'd maybe just ask in a little more detail. As I was looking at your paper as you were presenting it, it's that there are a few centers in each country, perhaps more in some countries than others or continents. There are 3 centers in India, for example. How representative are they of the entire country? And for example, TPN, being born in India, I can at least claim that. I know that it would be difficult to afford TPN and perhaps most medical centers in that country. So I just wonder whether this is more of a quaternary center experience, whether they're representative, and whether you could comment on that aspect.
Clearly, there are 3 sites from India, very high volume enrolling sites, but I think these are referring sites, all 3, and likely do not represent or partially represent the practice in smaller hospitals and community hospitals in India. We actually went back to our investigators and tried to talk with them and try to get a better understanding of why were these differences. And one thing that I can say for India is that and India had the highest rate of severe pancreatitis and necrotizing pancreatitis. So clearly there was a referral bias of those sicker patients going to these sites. And for example, they shared with us that the patients themselves prefer to have the gallbladder resection, the cholecystectomy locally at home. That's why, for example, the same admission cholecystectomy was relatively low in India. So clearly there are some of those discrepancies in patterns can be explained by the referral pattern of the institutions involved, 100%.
Thanks very much. Even though we're suffering from a COVID pandemic in the United States, we are still in the midst of an opioid epidemic. And I was struck by the fact that so many other places, particularly Europe, had very little use of opioids. Could you comment on how they do that and what we might learn from them?
Coming from Europe and from Greece, I do remember the days as a medical student that we're only going to use pethidine, which is almost like morphine, in patients with actually an attack of heart failure to decompress the right side of the heart. So I think it's a cultural thing, but clearly opiates are not wide. I was shocked when I first came to the US 20-something years ago. They're not widely available. It's not even an option out there, at least in European sites that I can comment. And also there is a study out there that compares, for example, non-steroidals with opiates in acute pancreatitis, and there's not significant benefit on the use of opiates. So I think it's a matter of culture, and we need a lot of work in this direction, especially being on the in the midst of an opiate epidemic that resulted in a lot of outpatients overdoses and deaths, on an annual basis. So I think it's a mindset for both patients and providers, and definitely we need a lot of work towards that direction.
All right. Thank you, George. Since we are at about 4 o'clock here, we will wrap up the session here, and we have a 15-minute break to follow, and then the session on chronic pancreatitis follows that. Thanks to all the speakers. That was an excellent session.